in the same university. As we are all aware that COVID-19 pandemic has changed our world and impacted multiple layers of our society. Therefore, the integration of a robot as a shielding layer, physically separating surgeons in the same university. As we are all aware. Therefore, the integration of a robot as a shielding layer, physically separating surgeons and patients, is a powerful tool to combat the fear of COVID-19 and maintain surgical volumes. Having said that, should we only depend on robots and maintain the high cost, or laparoscopic surgery is sufficient? Tonight, the discussion will present the most recent information and update regarding the comparison between TATME and robotic approach in low rectal cancer and its technical aspects and outcomes. This talk will be by our great colorectal surgeons who are eminent in their fields. Let me introduce you the two experts who are going to talk about TATME in low rectal cancer. First speaker is Professor Ahmed Farag, one of well-known skilled colorectal surgeons in Egypt. He is graduated from Qasr al-Aini and currently is a professor of Cairo University. He is also the head of colorectal unit in Qasr al-Aini Hospital. He is involved in many researches and medical education. Also, he has many international publications in colorectal surgery. The second speaker is Professor Khaled Madbouly, who is another professor from my second beloved country, Egypt. He's a consultant colorectal surgeon in Cleveland Clinic, Abu Dhabi. Prior joining, he was professor and chief of staff of the Department of Surgery in Alexandria University. Professor Khaled completed his colorectal surgery fellowship at Cleveland Clinic, Ohio. He also received a specialist colorectal training at the University of Lübeck, Germany. He is also the current president of Egyptian Society of Colon and Rectal Surgery. Dear attendees, I would like to draw your attention. All your questions will be answered at the end of the talk. So kindly write your questions in the question and answer box. And if you have any questions to a specific speaker, you can write his name so we can direct the questions to him accordingly. Professor Ahmed Farag, the mic is yours. I'm going to stop share.
Thank you, Professor Sarah. Can you hear me now? Can you hear me?
Yes, clearly.
Hello? Yeah.
Yes.
Thank you, Professor Sarah, for inviting me to be part of this very important meeting. And my congratulations to you and to the Emirates Society of Colorectal Surgeons. And I'm looking for our cooperation to have the Arab Society of Colorectal Surgeons, actually, and maybe the Arab Journal of Colorectal Disease, which we are in bad need. If you allow me, I'll share my screen right now. Okay, I have to say that there is no conflict of interest in any of the information mentioned in this lecture, and I'll proceed in this lecture as fast as I can to keep on time, but I'll discuss.
We cannot see your presentation. We still can see your computer.
Okay.
Would you please stop sharing and share again, and make sure to choose sharing the screen, the first choice.
Okay. Can you see it? Can you see it now?
Loading, sir.
Loading.
Yes, sir. It's full screen now. You can go.
Okay, thank you. We'll discuss the technique concerns of the technique, the reported recurrence rate or carbon dioxide embolism, our experience customer any in single team approach, why we had chosen this team, our single team approach, and a short study on comparison of transanal total mesorectal excision and robotic in Cairo University, and conclusions and recommendations. Of course, the techniques we know that we have the open laparoscopic robotic, but the transanal mesorectal, the attraction is that it's the first real notes we have in medicine. These are important points at the history of colorectal surgery and rectal excision for cancer. And the aim with any technique is to achieve an RO excision and to be in the right holy plane. And this is the problem that we started this technique without describing the holy plane from below. While sparing the important structures like autonomic nerve plexus, non-visceral presacral fat, paired side wall fascia, which is very important in the resection to see it, the hypogastric plexus, seminal vesicles, prostate, and vagina. We have to remember photo when we are discussing the section below, and notice that the pelvis is tilted. We forget always that the pelvis is tilted, and when we go to this plane, we have to go not parallel to the wall of the rectum, but we have to go at right angle to the wall of the rectum to have the proper plane from behind. The transanal total mesorectal excision is not different from other techniques. To resect the rectum, we have to have the mesorectum totally. So it's the most important point, which we have to, it's not the how to approach the rectum, but please achieve the proper resection. And it had been proved in many of the studies that it can achieve this goal. And we can see one of the specimens, the nice specimen of the total mesorectal excision. And it's the new evolution to go through the incision laparoscopic surgery. We started this and be able after that to go transanally. And actually, it's a complex operation because it needs a surgeon who's trained properly in the laparoscopic, robotic, or open total mesorectal excision with the intersphincteric resection, and Braxton cadavers can help in this. The debate, which is single team approach or two team approach, why you had chosen the single team approach, we can notice from this slide that can see the busy OR on the two team approach and the simpler, cheaper, and easier single team approach. But if there is any difference, definitely we take care that the chemoradiation should be taken, and the ureteric catheterization we do it as a routine in our hospital. The gel point, many advanced access platform is ideal. This is my approach to the laparoscopic colorectal surgery. Any type of colectomy or prostatectomy can be done with this 5-port approach. This is the why we had chosen this single team. On the right side of the screen, while we are operating from below, we have to have it's fully flexed. If you go halfway between, neither the abdominal team nor the anal team will be happy, and they can do some mistakes, and they can go into the wrong plane because they are not happy with the position. As we remember in our basic teaching, position on table is one of the most important steps in surgery. the abdominal part is performed as usual. We take down the inferior mesenteric artery at its origin and vein and mobilize the splenic flexure. And this is a short video. If we can operate, it can work, but I don't know if it will work or not. But this to show that we can go as low as possible with the laparoscopic. We can do the intersphincteric resection from above with the laparoscope now in 90% of the cases. But why to have the transanal? We can see the approach in the transanal. We can do it the Lone Star retractor and the gel point, but simply we are trying to have the resources or they don't have this retractor. We can use simple sutures like what you see, and we can insert our port in the left, start our dissection circumferentially, and go into the right planes through the port. We use the 2D camera. We use a constant and intermittent flow insufflator, and we can use the traditional no spatial instruments used for the technique. We can use the laparoscopic instruments, so we can make this technique available for everyone. We are not interested to be like gods on the Olymp mountain trying to do the technique. No one can do it, and we can go to the right plane using this platform, which is very simple, and we can do it. This is a video showing a procedure. We go from above, not to stop just at the peritoneal reflection, like the two teams, but we go as much as we can. We have to see the ureters, the hypogastrics, protect them, the seminal vesicle, and even up to the down to the top of the prostate, the middle or even lower third of the vagina, and if there is a problem, we proceed from below. This is the video of a section where we started to open the posterior plane from below. I don't know why there is a problem with the running videos. We tried it yesterday, but no problem. We can see that we can go to the right plane and do this. The number of surgeons started with this technique after training without having the proper 9.5%. Versus 3%, which is accepted in the laparoscopic or open or even robotic colorectal surgery, rectal resection. What is the explanation for this and how to avoid this? Simply, we actually show you the photos of this ligament. It's an important ligament, which is the uterosacral ligament, which is well described. There is an analog to this in males. They didn't describe clearly until we described this with pictures from a medical surgeon and anatomist, and we published this in Peripreniology, January 2019. What this ligament can give us in the uterosacral ligament in females, we can see it had been confused with the recto-ureteralis. It's not a recto-ureteralis, as is proved by the histological sections we have on this ligament. Actually, this is how the ligament looks like in the male. Ligament similar to that found in females. But what's the important that if we go inside this ligament, we don't see this ligament from its start in the female and pubis from males, and in both it ends on the fourth piece of the same. Inside ligament. What I call the space between the two ligaments in males and females, the innermost. This is improper for cancer, but the proper plane is here, where we can see the pelvic fascia. This is it means ligament from behind where the cancer from. This is the fascia. Lateral to the ligament to see this fascia. If you don't see this fascia, you can't say that it's a comparison between transanal total mesorectal excision and other techniques. It's the wrong plane. You go through the wrong plane. Through this plane, go to the second plane, which is you can see this view with the laparoscope or with the robot. But in one of the lectures or presentations by Professor Lacey, said, I always see this structure, but I don't know what it is. I met him in Cairo and I told him this is the posterior part of future without even know with and you can see the histology is the ligament must be the only way to the the bottom this eyes for me and they shared the concept of this paper, and you can see there is a lot of some muscles, elastic fibers and nerve fibers. You can see the plane here, the right plane, where you can see the pelvic dissection, which is clear from the ecchymosis due to dissection from above. This is how the lateral pelvic fascia is seen. This is the real holy plane from below, which has not been described before. The anastomosis will be discussed with Professor Madbouly. And actually, the major steps in the operation are the same, done from above, but we consider this part of operation as a completion operation. If you can go from above properly, you have to do it from below, but you have to have a lot of cases in order to be experienced from below, and that's why we had this series of 60 cases. We have 60 patients of both sexes. The results of our study, this is the frequency regarding male and female distribution pathology. Most of them were adenocarcinoma, most of them were grade stage 3 or 2, and 22 cases mid-rectum, 16 low rectum, and actually this is the intrasphincteric and the resection group. And diverting ileostomy was not done as a routine, and they can discuss this after. We used to have it as a routine, and then we stopped doing this because it increases the incidence of LARS. And regarding the operative time, you can notice it's a wonderful operative time. It's 155 minutes down to 2 hours, 15 minutes, because we use single team. The abdominal team, I work easily, and then convert the patient in the proper position, do the transanal part, which is maybe 9 or 10 minutes, up to 20 minutes, not 1 hour, like it's done by 2 teams. Estimated blood loss is very accepted. The distal margin is, and the distal safety margin, our group is 2.8 centimeters. The margin was completed in 100% of the cases. We don't have T4 cases too much, but this is our results. The average number of lymph nodes, we can notice that is the average 13 on the border, but we have chemoradiotherapy in most of the low rectal cancer cases. Average hospital stay and suffering from low anterior resection. None of the patients complaining of urethral problem despite 2 urethral injuries repaired. And injury patients, post-operative ED, and 2 cases were covered, converted to open approach. One of them because the large size of the tumor couldn't be extracted from the inner canal node because of the difficulty in the technique. And actually, we reviewed similar studies and found that our operative time is much, much less than the 2-team approach in other teams, but we have to do it in the same center with the same surgeons, so we can minimize it. The problem of pulmonary embolism with the carbon embolism with the transanal is mainly, we believe, that is due to constant flow insufflator, which keeps pushing carbon dioxide into open veins if they are open, while we are using the intermittent insufflator with no problem in doing the technique, and we didn't have a single case of this embolism. We recommend single team because it can achieve the same or lower operative time due to better position of the patient in each phase of operation and protection of the ureters, hypogastric, and similar vesicles before we start the perineal phase, so we can go laterally as much as we can. Definitely, it's our experience. It's with the 2D camera, intermittent flow insufflator, and zero scope. I don't use 30. I don't find any problem with the zero scope, and you can move freely without having this compulsory direction of the power cord to the scope, which can hinder protection of the cancer completion operation. I'll go fast through the comparison of the two techniques done in Cairo University. Actually, we recommend this, that the transanal Holy plane should be in the plane we described finding of the ligament, and to go at right angle to the wall of the rectum, not to go tangential to the wall of the rectum. This is the robotic anterior versus transanal, and we are preparing this paper for publication. Randomized. It's their bench robot, and in our center, 27 cases into each arm. And it's a case series rather than a randomized trial. And this is Mechanical Institute, and this is our university. And we have the distribution, male and female were equal histopathology. And we can notice that the stages are nearly equal, but more early stages in the transanal in the our group, and more advanced cases, little bit maybe to the presentation to the Cancer Institute of more advanced cases. And we can notice that the total time is shorter with the transanal. Preparation time is definitely shorter. Actual time is shorter with transanal. Leading with the robotic is higher, maybe due to their but prevention version of completion our 20 patients in 100%. Again, this adds to our 60 to become 80. But in 18 only in the robotic, maybe also due to the advanced nature of the resistant, despite the fact that there is no difference in the total number of lymph nodes resected in the two groups, but higher nodes in the robotic maybe explain also the higher grade of the or stage of the disease. There was no significance. Hospital stay was shorter with the robotic, significantly shorter, and the cost is definitely higher with the robotic. Total cost per case definitely higher. And in conclusion, this study suggests that robotic has some advantages. Robotic resection was achieved. And even be done with the robotic transit. We have lots of robotic transit. Preliminary data on complications, short-term on good to our suggested plane lateral to the heterosexual ligament analog. Higher recurrence rate, maybe to improve participation, and the introduction of the ESCRS that in order to give a CPR for this a dying technique or threatened technique to be eliminated from our practice. We think that it's a very good technique as a complementary procedure and reduction of as a single team approach and as a completion operation, laparoscopic or robotic operation using intermittent flow supply is the only way to keep this.
I think Professor Ahmed ended his presentation. I can't hear him.
Yeah.
Thank you, Professor Ahmed. Our second speaker is Professor Khaled Madbouly. If you can share your screen. Thank you.
Thank you, Sarah, for the invitation for this meeting, and thanks for the Emirati Society of Colorectal Surgeons. And I got a warning yesterday from Rogers that I have to finish early because Sweden is going to play today. So I'll try to be fast. Dr. Ahmed Farag talked about the technique of the TATME. I'm not going to talk about the technique. I'm going to talk about the second steps that probably nobody is going to argue about it, is that you should have anastomosis after resecting the rectum. So these are my disclosures. I don't think that any of them is related to the TATME. Probably they are from the other side of the game, that these companies are not used in TATME procedures. Specimen retrieval and formation of anastomosis are probably the most critical steps of the TATME procedure. We have a lot of anastomotic techniques. Probably I'm going to summarize. You can do it immediate or delayed anastomosis. It can be hand-sewn or stapled. And for each of the hand-sewn and stapled anastomosis, it can be end-to-end, into-side, or colonic J-pouch. And for the stapled procedure, you can use the hemorrhoid stapler anastomosis, or you can use the modified circular stapler anastomosis, and sometimes the modified pull-through circular stapled anastomosis. We're going to talk about all of these, and probably we're going to talk about the turnable cote pull-through, which is procedure I like personally, because a lot of patients here in this region are trying to avoid stoma. So probably, this is helping us to avoid stoma in these patients. First, let's talk about the specimen retrieval. We have one of two options, either to retrieve it abdominally or to retrieve it transanally. If you're going to do it abdominally, so you're having the risk of hernia because you're having an incision. However, you can see everything and you can do the resection easily. And, if it is a big tumor, you can resect it without excessive dilatation of the inner canal. For the transanal retrieval, yes, you're not having any incision, so the patient is not going to complain of any incision problem. However, if the tumor is big, it will be a little bit hard to retrieve it transanal. And I'll tell you, on a surprise from the International TATME registry, people who got transanal retrieval of a specimen got less anastomotic failure in the results in the univariate analysis. However, it didn't hold in the multivariate analysis. So probably we have to think about it. Why the transanal retrieval might be of benefit for the patient, although it can be very hard if the tumor is big. For the hand-sewn coloanal anastomosis, first of all, you have the descending colon should be delivered to the pelvis, and probably this is a hard step because usually the pelvis is very deep because we are using a TATME sometimes in male pelvis, which is narrow. And so sometimes we put a catheter in the lumen in order to help to deliver the colon into the anal canal, avoiding any twist. And probably a Lone Star retractor, which is a self-retaining retractor, can help you for better visualization and better positioning of the colon at the anal canal. For me, I use one layer anastomosis, interrupted 3O or TO or TO 2O vicryl. Each suture should incorporate the mucosa of the inner rectal cuff and portion of the upper internal sphincter, and then I take a full thickness of the muscle layer of the colon, patting the mucosa of the colon. So I start from here. I take the mucosa and part of the inner sphincter muscle, and then I take the whole colon muscle, patting the colonic mucosa. This is how I do it. Usually I put between 8 and 9 sutures on the circumference of the colon. And this is usually how it ends like this. And I can do it end to end like the previous picture, or end to side like this one. And sometimes we can have a colonic J pouch, and probably we're going to talk about it later, about the functional outcome of this colonic J pouch. The other side of the game is that we are not going to do it hand sewing, we are going to do it stapled. And this stapled, the principle is to do double burst string circular staple. And this is the principle. The TATME allow you to do stapling without the cross stapling. So we are not going to cut using the TA or contour. So we have a crossing stapler. We have only one staple line. So the first step is that usually you should have a full thickness burst string suture with a 2O prolene at the open rectal stump. And the burst string should be without gaps. And the burst string can be placed either through a gel point for colorectal anastomosis or just open through the inner canal for a coloanal anastomosis. And here are the steps. First, you can use a hemorrhoidal stapler anastomosis. So you put the anvil at the terminal part of the colon, and then you take a burst string at the rectal stump, and through this long anvil of the hemorrhoidal stapler anastomosis, you can just pull it to the gun and place it together and have anastomosis between the both ends. And we are going to see a short video about it to see how it can be applied. This is a transanal, this is a Lone Star retractor, and we are going to put a burst string at the open rectal stump. This is coloanal, so we are not going to use the gel point. We're just going to put it open. And now we fix it in order to have insufflation of the abdomen without problem. We're going to put the anvil through an intraotomy or through a burst string, no much difference. So I'm going to advance. So we're going to, now the anvil is ready. We're going to pull it transanal like this through the burst string, and then we're going to hook it together and then tie the burst string and do the stapled anastomosis. And then take out the circular stapler, 2 complete donuts, so you're now safe that you're having good sound anastomosis. Usually in these cases, I do proximal diversion. I know some people are not doing it, but for me, I do it. The second option is to have the modified circular stapled anastomosis. Again, proximal colon, you put the anvil, and then transanal, you put the gun with a ready bag drain at the central rod, so that this ready bag drain is gonna guide you where is the rectal stump, because sometimes it's very hard to see while you're doing it laparoscopically. The ready bag drain acts as a guide to ensure the perfect central position through the center of the rectal burst string, and the laparoscopic operator is then able to remove the drain and covering the spindle intra-abdominally, and with the assistance of laparoscopic grasper, the anvil and spindle are connected. And again, this is a short video how it can be done. This is the start of the procedure. I'm gonna it's 1 minute video. This is how we started the procedure, and we started the dissection. I'm gonna pass all of these. After we have done everything, we have detected everything, we're gonna go, okay, let's go back a little bit. Okay, here you go. Now the specimen is retrieved, and now we are pulling the anvil down below in order to be sure that it reaches. And then we take a burst string, transanal like this. We take a burst string here, and we know the anvil can reach. And then we put the gun with a ready vac like this in order to be sure that this is a place. And then we pull out the ready vac. And now we have the spindle here, and we hook it with the anvil, and we do the anastomosis. And again, in these cases, we usually do diversion for these patients. Okay, and the third option to have a modified pull-through circular stapled anastomosis. Again, anvil in the colon, and we have the white plastic sharp cap. We can put it, attach it to the anvil with the monofilament at this cap. And this monofilament, we're going to use it to pull transanal in order to guide the anvil to the transanal purse string. Probably this is a video is going to help us to understand. This is the anvil. We're going to pull it down here. We're going to put the purse string transanal. Okay, and now we're going to pull the anvil through the wire, hook it together, and then tie the purse string and do the anastomosis. So probably these are basically the three techniques that we are using in order to avoid any difficulty in having the stable anastomosis during the TATME. The turnable cote, again, it's a pull-through technique where we are just doing the normal dissection as we used to do. And then after we are completing everything, we're gonna mobilize the splenic flexure in order to have extra length so that the colon can be pulled down through the anal canal. And when the colon is pulled out through the anal canal, I'm gonna use a picture now. Okay, now, okay, just let me go back. Okay, this is a picture, this is the end picture. The colon is pulled down through the anal canal, and then we fix the colon through 4 stitches into the perianal skin, and we'll leave the colon like this. And in this case, the patient should stay in a hospital for 5 to 7 days for everything to stick together. And probably after 2 or 3 days, you're gonna find that this part of the colon is dusky and the patient will be incontinent. This is gonna happen for 5 to 7 days. And after 5 to 7 days, you're gonna take the patient back to the OR and amputate this part of the colon and do the coloanal anastomosis in the same way that we talked about it in the coloanal anastomosis. And in this situation, probably you will not need to have diversion for this patient because everything already stuck together for the week that we talked about. Okay. So after that, yeah, we're gonna do the coloanal anastomosis after amputation of the redundant colon outside the inner verge. Just take care that you must have extra length of the colon with a good blood supply. Otherwise, you're gonna find everything black and you cannot do the anastomosis. We made a comparison between the immediate and delayed coloanal anastomosis. This paper impressed in surgical endoscopy, and probably we're gonna find it within the next few months. Operative time for us, no much difference, around 3 hours for either the TATME with immediate anastomosis and diversion or with a turnable cote. Anastomotically, probably comparable. Anastomotic stenosis, again, the same, although we know that with the turnable cote, in many publications, it's higher, but for us, no much difference. As expected, the stoma complication with the immediate anastomosis because in turnable cote, no stoma. But look at this. Permanent stoma after 2 years, 20% in the immediate anastomosis and 20% in the turnable cote. Probably most of them are due to low anterior resection syndrome, and probably Rogers is going to talk about it. However, it's just painful part of the procedures that if you're going to do very low anterior resection with coloanal, you have to deal with the low anterior resection syndrome because it's usually one of the complications that the patients complain for a long time. The readmissions, no big difference between post-procedure. But look at this, the continence. Again, no difference in the continence. Median local recurrence, no difference, although we're having pretty high local recurrence, 12 and 15%. Maybe because of the small number, maybe because we used a little bit advanced cases. Some of our cases were mucinous. Maybe it was part of the learning curve. You know, why we're having such a little bit high recurrence, and no different. And this study compared the functional outcome of the low rectal tumor compared between the transanal and with laparoscopic total mesorectal excision. And look at this, the major low anterior section syndrome, almost half of the cases of the laparoscopic and 35% of the cases of the transanal. I know no significant difference, but again, the numbers are scary. 52% and 35%, again, very high numbers. For when we compared between the end-to-end and the colonic J pouch, again, we all know that with the colonic J pouch, we used to have some evacuation problem, although the continence is better. Compared to the end-to-end anastomosis, continence is worse. However, the evacuation is much easier. Again, it's a debatable issue. I don't think that a lot of people are doing colonic J pouch nowadays. Personally, I don't, but you know, it's part of the techniques that are available, and some people like to use it. And this is the international TATME registry, more than 1,500 cases, almost 1,600 cases. And look at this, the anastomotic leak rate can be early or delayed, or anastomotic fistula or anastomotic stricture. And the anastomotic technique could be manual or stabled. We're having, you know, probably stabled are double the manual ones. And look at this, the multivariate analysis for the risk factors of early anastomotic leak. We found that the sex, male sex, high BMI, smokers, diabetic, big tumors. And with the estimated blood loss, which is more than 500 cc, all these are risk factors of early anastomotic leak. For the overall anastomotic failure, again, male sex, high BMI, smoker, diabetic, high tumor size, and high estimated blood loss, and longer OR time, and the intraoperative problems. I think all of them are expected. So in summary, specimen retrieval after TATME better than transanal. Colorectal anastomosis is done immediately, usually with fecal diversion, and coloanal can be done immediate, usually with fecal diversion, or delayed without diversion. Colorectal or coloanal anastomosis can be done hand-sewn or stabled. Colorectal or coloanal anastomosis can be done end-to-end, end-to-side, or colonic J pouch. Low anterior section syndrome is an issue that we need to think about it with the TATME. Early anastomotic failure is more common in male, obese, smoker, diabetic with large tumor, and there's no significant difference between immediate or delayed anastomosis as regard leak and the functional outcome, and no significant difference between laparoscopic or TATME anastomosis as regards the leak and the functional outcome. Manual technique is more associated with anastomotic stricture, and excessive blood loss is posing a high risk on overall anastomotic failure. Thank you very much, and we invite all of you to attend the Egyptian Society of Colon Director Surgeon meeting at the 1st of September this year. We hope to see all of you there. It will be a physical meeting or a hybrid meeting, physical and online meeting. Thank you very much.
Thank you, Professor Khaled. Dr. Intak is going to present his part of robotic approach in low rectal cancer.
Any other? We will have the question and answer session in all.
At the end, Doctor.
Okay.
At the end of the speakers.
Okay. Okay.
All right.
Okay, thank you so much for two nice presentation. I would like to move to robotic approach for low rectal cancer treatment. In this session, the outstanding speaker will present about the two topics. First topic is Dr. Rogery will present. The robotic approach for rectal cancer in ERA setting. And second lecture in Dr. Professor Choi. He will present clinical applications of the Da Vinci SP for rectal cancer treatment. I want to introduce initially the Dr. Professor Gerry. Dr. Gerry has trained and practiced general surgery and colorectal surgery in Sweden and has 20 years of experience in general surgery and colorectal surgery. With his early interest in proctology, he published several papers in this topic and accomplished his PhD degree in 2008. He is internationally known for his efforts in robotic and laparoscopic surgery in colorectal disease, and he's often invited as a speaker at international conferences. And currently, he's a scientific committee chairperson in ESCRS, and he's working as consultant colorectal surgeon in Mediclinic City Hospital in Dubai. And then I want to introduce a second speaker, Professor Dr. Choi. Professor Choi, he graduated from the School of Medicine at Kyungpook National University and completed his surgical residency at same hospital, Daegu, Korea. He received degree of PhD at the same university, and he completed a research fellowship for cancer genetics at Cancer Research UK, Oxford. After his return to Korea, Professor Choi organized minimally invasive surgery training and research center at Kyungpook National University Hospital, and he is one of the early pioneers of robotic colorectal surgery, and he developed one of the first Da Vinci low enter resection and Da Vinci light colectomy procedure technique material with intuitive surgical. Currently, he is a professor and head of Colorectal Cancer Center and director of Minimally Invasive Surgery and Robotic Surgery Training and Research Center, Kyungpook National University Medical Center, Daegu, Korea. Firstly, I would like to request Professor Rogery. He will present his presentation today.
Thank you, Intak, for the nice presentation, and thank you, ESCRS and Sarah and all the previous presenter. I'm honored to be here, and I will try to talk a little bit about robotic surgery now. First of all, I would just like to say, everybody at 5 o'clock, you should go and watch the soccer, okay? Let's see, there we go.
Go Sweden.
So,
go Sweden.
Go Sweden. I moved to Dubai 2 years ago, but I'm going to talk mainly of my robotic experience from Stockholm, Sweden, and what I've done there. This is my disclosure. I'm proctor for Intuitive. The thing is that the last 3 decades, there have been very big advances in colorectal surgery. Bill Heel came with the TATME Holy Plane. After that, it was mainly in the 90s laparoscopic surgery and year 2000 enhanced recovery programs for pre and post-op care of colorectal patients. And you can question yourself, is it TATME or is it robotic surgery that will be the next development for colorectal cancer cases? Robotic surgery has been now for over a decade. It's almost 1.5 procedures done every year, mainly in Europe, US, and also South Korea. It has been an explosive implementation. And now it's almost mandatory to have it in your hospital to recruit patients for urology, gynae, or colorectal cancer cases. And even now, I'm doing a lot of general abdominal surgery, so it's the same thing there. In Sweden, definitely, it has become an important issue to recruit surgeons to your facility, and I'm sure it is like that in Europe and US too. Let's talk a little bit about enhanced recovery. The enhanced recovery is all about minimizing the surgical stress that we do when we do the operation. When we do the surgeries, and if it's major surgeries, it will be a stress reaction for the body and release of a lot of cytokines and hormones. And all this will cause an oxidative stress, which will cause a suppression in the immune system. And the theory of that is that it will decrease the elimination of disseminated tumor cells. And we might have recurrence due to complications or the surgical stress. The ERAS items is based on things that could lower the surgical stress. As you see here in the x-axis, it's the level of evidence of the different items, and on the y-axis is the pre-operative items and intra and post-operative items. As you see, a few years ago, like anemia was in the low level of evidence, and now it's climbed to to high level of evidence. We should treat anemia before we do any operation. The same thing with antibiotics. We should. I usually don't give bowel preps unless I'm going to put up a diverging stoma. Post-operative and pre-operative, for me, very important. With euvolemia, we can say that every kilogram gain post-operative for the patient is 1 day extra length of stay, which, I mean, an operation, if we give too much fluids and the patient gain 10 kilos, that means 10 extra days of stay. I stopped using drains. I stopped using epidural, all according to the ERAS protocols. Another thing about the ERAS is that the compliance is crucial. You can have an ERAS setting in your facility, but you don't have the compliance. The nurses doesn't follow it, all the doctors doesn't follow it, and so on. And you see that there will be significant difference depending on the compliance when it comes to symptoms and readmission and so on. And also the long-term outcome is actually different if you have a compliance with a margin less or above 70%. So compliance for the ERAS protocol is actually very important. So I'm going to talk about Danderyds Hospital, where I worked in Stockholm, and I'm going to tell you how we transformed from laparoscopic to robotic. When I came to Danderyds Hospital, first of all, they was one of the hospitals that done most laparoscopic surgery for colorectal and started in 2007. We were in Sweden very late adopters for laparoscopic surgery. And they started with the enhanced recovery program 2010 and retrieved the database 2011. And now when I was there was Center of Excellence of ERAS. I moved there in 2014 and we started with the robotic program there. And we did a study with actually comparing laparoscopic surgery period from January 2011 to April 2014, and then we started with robotic, and we compared the robotic era to the laparoscopic era. We could see already when we did this comparison that we went from minimal invasive approach for rectal cancer from 46% to 71%. 2 years after the study was done, our minimal invasive approach for rectal cancer cases was almost 90%. The basic characteristics for the two groups, robotic and laparoscopic, was similar. We could actually see that the age was lower for robotic, and there were more male in the groups, I think. But I think we didn't have an explanation. I think we started with more screening for rectal cancer during that period. Here's some intraoperative details. We had definitely longer operating hour for robotic compared to laparoscopic, but we have to take in concern that I was actually training 2 other surgeons doing robotic surgery during that time. We stopped doing drains, so that was more protocol change in the ERAS setting. And we stopped the epidurals, which was also change in the ERAS protocol. But look at the conversion. We went from 34% in laparoscopic group down to 11% in the robotic group as conversion. Here's where things become interesting. This is the soft outcome measurements. This is data that nurses are registering in the wards and telling us how the patient is feeling post-operative. And you see that every single soft outcome measure is actually better for the robotic group. They start to eat earlier. The urinary catheter is moved earlier. They have flatus earlier. Pain control. And pain control is visual analog scale less than 4 on oral analgesics. And look at the difference. It's 1 day for the robotics and almost 5 days for the laparoscopic group. Hours out of bed also improved in the robotic group and so on. So this tells us that the patients are feeling much better when we're doing robotic surgery compared to laparoscopic surgery. The pathology was all the same, no difference, but you can see that we actually had a little more lymph node harvest in the robotic group, not significant, but some more extra lymph nodes. And here's the main outcomes. No mortalities, thank God. Length of stay, we reduced the length of stay from laparoscopy 7 days to robotic 3 days. And we actually reduced the complication rate, and it was mainly actually clavia-dindo 1 and 2. So we had the same amount of anastomotic leak and so on because that part was done more laparoscopic. We had a little bit increased readmission, not significant, but the readmission rate, if you send home the patient day 3, you will probably end up with having more readmissions. So in conclusion, yeah, when we looked at the data, we had more male, more advanced cancers. They had more chemotherapy, so we selected maybe more difficult cases for the robot. We definitely reduced the conversion rate from 34% to 11%, and just a few years before I left there, the conversion rate was less than 4%. Improved compliance to the postoperative ERAS items, so we could send home the patients day 3, which reduced the length of stay with median 4 days, and also significant reduction of all complications. So I don't know, but we have asked ourselves why the difference, and because we're actually doing the same procedure, but we're using different tools. I believe it's all about the causing less surgical trauma, causing less surgical stress. And you see on the left-hand side, you have a laparoscopic medial to lateral dissection. You see the ureter there. And on the left-hand side, you have a robotic medial to lateral dissection. What we do is that when we dissect with the laparoscopy, we do more blunt dissection, while when we dissect with the robot, we do more of energy dissection. And I think that keeps us in the correct planes, and I think that causes less trauma. So when I try to do laparoscopic procedures nowadays, I try to use more energy. And we also looked at the C-reactive protein day one after surgery. For me, C-reactive protein day one after surgery just gives you the surgical stress and surgical trauma for the surgery. You can't have an infection or anything so early. And you can see that there was a significant difference in the C-reactive protein levels. Another picture, patient satisfaction. This is, I think, Khaled told us, anastomotic, this is a patient, high BMI, male, a low tumor. I did the operation, and this is actually day one after surgery. He was feeling great. You see the stoma there. I always divert my low rectal cancers. This is actually what his specimen looked like, and everybody usually say that with the robot, one of the disadvantages, you don't have a tactile feedback. If you look at this specimen, you see that the planes are really nice. There's no tear in the tissue because you somehow develop a visual tactile feedback, so you don't need the tactile feedback from the instruments. You can see it with your eyes. This is a lady I did, and this picture is taken 3 weeks after surgery, and she was feeling great and wanted to start going to the gym. And this is another picture. I usually in Sweden had my operation dates on Mondays and Tuesdays. On the left-hand side, you see the Monday patient. On the right-hand side, you see the Tuesday patient. And this picture is taken on a Thursday, and both patients are going home. So length of stay of 3 days and 2 days for these patients. I just want to show you a little bit the benefits of the robot, the things that I actually just saw in the literature, but never seen when I did laparoscopic or open surgery. This is the hypogastric nerve and the lateral pelvic fascia and the erogant nerves. And if you just go into this plane, you will cause erectile dysfunction and so on for the patients. So that is actually, I think, a severe complication. And this is a patient I did just last week. And look at the image and look at the dissection plane, and all of a sudden you see those lateral nerve plexus coming there, and you can just avoid them just beautifully with the robotics. You see the ureter on the left-hand side, you see the nerves, and you could actually very easy just go in this fat and take the nerves, but here you see the plane correctly where you need to divide everything to loosen it up. And also the dissection all the way down to the pelvis is with the robotic not an issue anymore after all those years. Another thing is that I heard a lot that when you operate on females, they don't have adenovias fascia. And with the robotics, I always see the adenovias fascia and actually see almost often 2 layers. And here you see how I divide the adenovias fascia in a female patient and open it up to come down all the way down to the rectum. Just to show you the small things we can see with the robot. So in conclusion for me, I mean, yeah, the evidence is or maybe not there, but it will come there. I'm sure that the evidence will come there. But despite it, we like it or not, robotics is here to stay. The investments are here, and we have done them, and we're going to use the robot. The future potential is unbelievable. All the tools coming up, there are new tools coming up from Intuitive, which will ease up all the surgeries. And I'm hoping also the competition will come up, so we will have the less expensive instruments, because the problem for the robotics right now is the cost. That's the only disadvantage. We always talk about the money. Yes, it's too expensive. But the laparoscopic surgery was also very expensive in the 90s when it was introduced, and now it's standard. So in 5-10 years from now, robotic will be standard and hopefully not so much expensive. And we have not even discussed artificial intelligence. And just for Khaled and Ahmed, I think also that TATME will probably be done robotic in the future. And I think my colleague will discuss a little bit of the SP platform soon. Thank you so much. This is my contact if anyone wants to contact me, ask me anything, and I am done. I'll stop sharing my screen.
Thank you so much, Dr. Gerry, for your nice and informative presentation. And the second presentation in robotic rectal cancer surgery will be done Professor Choi. He will present the title, Clinical Application of Da Vinci SP for Rectal Cancer. Professor Choi, please.
Okay, can you see my slide?
Yes.
Okay. First of all, I'd like to thank for the invitation to the society, Emirates Society of Colorectal Surgery, and my dear friend, Dr. Lee, my the fellow, the most sincere person as I ever met. Today, I would like to share my initial experience of Da Vinci SP for rectal cancers. We started last year, I cannot remember, last July or August, we started the SP system in my unit. No disclosures. As you can imagine that the SP system is like the one single port which contains 4 instruments, including the scope and instruments, and diverge into the abdominal cavity and deploy and work in the narrow space. You may think SP has a dual intercorporeal articulation, which looks better than XI, because XI has only one wrist inside. But unfortunately, this is not true, because XI has more elbows and shoulders outside the body. The elbow joint in SP has a very limited function of deploying the instruments only. And the acting segment from the wrist and to the tip of the instrument is actually quite longer than the instruments of the XI. So it causes a less freedom in motion, especially in narrow space. Also, minimum required distance to the target is actually longer in SP system. You have to remember all these specific features of a SP system compared to the previous XI system. There are unique advantages of a SP system, which are the capability of a single docking and multi-quadrant approaches. Obviously, this is the best, the system who can cover the multi-quadrant, the organs with a single docking through a smaller incision and the flexible scope. But there are multiple disadvantages, such as the lack of instruments. So far, there are no staplers and no advanced energies and no suckers, irrigators. So this may affect surgeons more assistant dependent than XI, I believe, and the less precision, as I mentioned before. The scope is quite nearsighted. So you have to consider where to place the entry port first, which instrument you use, and how to use additional staplers and energy sources and suction irrigators, you may need very able assistant to do all these things. So we chose the entry port at the right low quadrant because it has a good angle to all targets for rectal cancer, from the spine fracture to the pelvis. Also, this incision can be used for stapling and the specimen retrieval, and also ileostomy if it is needed. And although SP can cover multi-quadrant with a single docking, it doesn't necessarily mean you never change anything. It needs multiple relocations since it has a limited range of surgical field with one location. So sequentially, you have to relocate from the spine fracture to the down to the pelvis. So the entry port has a 4 lumens. You can use 2 types, which are the camera on the top or camera on the bottom. We use the camera on the bottom approach to facilitate very good traction and countraction and triangulation during surgery with 3 different instruments, which are round tooth retractor and fenestrated bipolar and monopolar curved seizures. And this is the system, the robot approaches from the left side of patient and dock to the right low quadrant entry port. And this is for setup. At the right low quadrant, we introduce the uniport. For uniport is the Korean single port device for sharing robotic port and some of the assistant instrument. And one additional family port at the right up quadrant or upper midline, and mainly for traction by assistant. And this is a video clip showing port incision. Through a small incision at the right lower quadrant, uniport was inserted and the robot was docked from the left side to the right lower quadrant of the patient. Docking is quite simple. And then insert camera first and 3 more instruments as I showed before. As I mentioned before, there is a minimum requirement for the distance from the tip of the port to the target organ. So you please note the tip of the port is floating inside the space of the uniport, not in the body of the patient. We need a minimum distance to the target. And for low anterior resection, the surgery was commenced with the division of IMA and the ligation and divides IMA and IMB with the harmonious triangulation of the tissue by retractors and forceps. And then avascular dissection was extended to the inferior border of the pancreas to enter the lesser sac from below. Then we mobilized the spine fracture. And we completed medial to lateral and then moved to the lateral side to mobilize the remaining part of spine fracture. Here's the colon at the spine fracture, and we completely mobilized it. And then we relocate the system to the pelvis. And for the rectal mobilization, the round tooth retractor holds the rectum to help rectal mobilization by interfacial dissection of the mesorectum. The most important maneuver to complete TME for us to expose the surgical field is appropriate by coordinated traction and contraction. Please note how we effectively utilize the instruments for good visual fields. After traction and contraction with your retractors and your left hand, and your monopolar scissors actually is very simple. You can cut dissection between the avascular plane. This is anterior part of the rectum. We hold the prostate upward by retractors, and we gently depress the rectum with my left hand, and we can increase the space between the tenon-bilious fascia like this. And step by step, mobilization of the rectum very down to the pelvis. You can see the lebate muscle. And after full mobilization of the rectum, and there is no staplers, so we use the laparoscopic staplers through the right lower quadrant, and then divide the rectum, and the specimen was retrieved through the uniport, and anastomosis was done intercorporeally as usual. Then we returned the colon and make a pneumoperitoneum again, make a anastomosis. When lateral pelvic nose is involved, especially on the left side, we can dissect lateral pelvic nose as effectively as we can do with the XI system. Again, please look at how we use the retractors for good visual field. And then we dissect plane by plane in the pelvic side wall. You can see the external iliac artery and vein here. And we developed a plane between the pelvic side wall and the obturate group of the lymph node. And another plane is just medial to, just lateral to internal iliac artery and vein, the branches. And then we removed all the lymphoareolar tissues between these two planes, which is the obturate group of the lymph node. And we preserve obturate nerve here, whitish one. You can easily find, identify, and preserve it. While we preserve obturate artery and obturate nerve and some branches, but we remove all the lymphoareolar tissues on the pelvic side wall. This is internal iliac artery and branches. This is inferior vesical artery and vein, and we remove all these things. And then we capture the specimen with the plastic bag. This is a final view after lymph node dissection. And the ISR is actually, for me, is the most promising indication for SP system, because we can maximize the advantage of transanal dissection for intersphincter area with the naked eye and their high quality of robotic TATME from the above. And we start from transanal intersphincteric dissection. And we close the anus by pursuing shoots at dentate line, and after careful mobilization of the very distal rectum under direct vision up to probably 6 to 4 centimeter upward, and we move to excuse me, move to abdominal TATME as exactly the same as we do for normal lower anterior section. And we dock the lobot, and we continue mobilization of the rectum until we can make a long debut the space we developed from the below. You can see the gauze I packed after transanal dissection, intersphincteric resection. And then specimen can be delivered through the anus or through the right lower quadrant. And then we do Henshun anastomosis, coloanal anastomosis. So this is the final picture. The APR, you can do APR. This is one case, the example for APR. We for APR, the robotic port is inserted through the future colostomy site first, and then surgery was carried out to complete the TATME from the abdominal side. You can see it's like just a mirror image because the lobot is docked on the left side of the patient. It is medial to lateral, but it looks like a lateral to medial. After division of the colon and everything, the total mesorectal excision is quite simple and similar, as you can see here. We can dissect anterior, lateral, and posterior side of the rectum until we see that this patient has a vaginal invasion. So we open the vagina from the above. And then when you see the dentate levate muscle, and then we move to the perineal side and complete the perineal resection with the posterior wall of the vagina for this particular patient. And then we close the perineal wound with the vaginal wall. And then, as you can expect, there is only one port you can see here, because we introduced the lobot through the colostomy site. So actually, ESCRS surgery at the abdominal part. These are the result of initial 5 cases of operation, the 5 cases with SP system. The operation time was around 4 hours, docking time was 4 or 5 minutes, and the blood loss was very, very minimal. The CRM was clear in all patients. And we are planning to do RCT to compare the multi-port versus single-port rectal surgery. And the endpoints are non-inferiority of the SP system in quality of TATME and the functional outcomes, expecting better recovery in SP system. Preliminary results look promising with a short recovery in the SP group compared to the XI system, and CRM positivity is very low. These are some examples of our multi-organ resection with a single port robotic surgery related with the colorectal surgery, and we did colorectal resection associated with hepatectomy and gastrectomy or lateral pelvic node dissection, synchronous double primary surgeries with all SP systems. In conclusion, single port surgery using Da Vinci SP system for rectal cancer with or without multi-organ resection is quite feasible. It may reduce abdominal incision, which may enhance the recovery and cosmesis. In terms of fidelity of precision, SP may be compatible to XI, but never superior. So this is my experience of SP system. If time permits, I can show you some the robotic the study results of the comparative studies. If it's not enough time, so I have to stop here.
You can go ahead, Professor Choi.
Can I take 5 more minutes?
Yes, you can go ahead with 5 more minutes.
Okay, thank you. I would like to show you some long-term results of robotic versus laparoscopic rectal cancer surgery. This is our randomized clinical trial, the so-called COLA trial, comparison laparoscopic robot for rectal cancer. 151 in robot and 144 in laparoscopy. And the demography of the patient, even after RCT, there is a little shorter the lower distance from the anal bulge in the robotic group compared to the laparoscopic surgery, just 6 millimeters. And our primary endpoint was a better completeness of TME, but actually the completeness of the TME between the two groups are quite similar. It's not significant. It's a little bit better in robotic group, but not significant. And the positive CRM is total group 4.8% and 6.2%, but not significant between the two groups. All other parameters are similar in pathology characteristics. And the morbidity, mortality, there are no mortalities. The morbidity is a little bit lower in the laparoscopic compared to the robot. But the basically is quite similar. And the global QOL and the Wexner scores in the bowel function is quite similar. And IIEF score for male sexual function, IPSS, the Boyden function for both genders are quite similar. So basically everything is the same for multi-center randomized, Korean randomized clinical trial. These are the recently published our own institutional data for long-term oncologic outcome comparing the lab versus robot in mid-low rectal cancers. And our conclusion was robot surgery in mid-low rectal cancer shows a similar long-term oncologic outcome, but only beneficial to a certain group of patients who had advanced rectal cancer with a poor response to the neoadjuvant chemoradiation. So we compared the 118 in the both group, and the 5-year relapse-free survivors are quite similar, 87, 86%, and the intrapelvic recurrence is 6.2% in lab and 5.6% in the robotic, and the distance recurrence is 10% in both groups. And we analyzed the risk factors for relapse-free survivors. We can expect it, as expected, the pre-op CCLT, pathologic T3/4, and advanced lymph node groups are the risk factors. And with combination of these risk factors, when the patient has 2 risk factors of CCLT and T3/4, pathologic T3/4, which means poor response to CCLT, their distant recurrence is far less in the robotic group compared to the laparoscopic surgery group. We cannot explain the reason why, but we may imagine that the most smooth manipulation of the rectum can reduce the tumor cell progression. And these are the results we already mentioned. So this is the short, brief report of our the long-term results of robotic surgery group. Thank you.
Thank you.
Thank you so much, Professor Choi. So now we can take the questions. Please, dear attendees, you write your question in your question and answer box. Dr. Intak, I'm going to take the first question and you can take the second one.
Okay.
So there's a question this is for the TATME speakers, for Professor Ahmed, Farag, and Professor Khaled. In TATME, what's the percentage of R0 resection, and is there any prospective data?
Actually, for prospective data, I think all our data are recent. You know, we don't have any old data. TATME started probably 6 years ago or 7 years ago when we did start. So for the resection margin, R0 resection, so I think most of the cases are R0 resection. Sometimes we're having 1 or 2 cases. You know, for us, we have probably 2% of our cases, actually 1 case, that have a positive resection margin, which is probably, I would say, it's pretty much the same like doing laparoscopic TME. I don't know what Professor Ahmed Farag have.
I agree, but in T2, T3, we have zero circumferential margin and good upper and lower margins. And I think maybe we have to include more T4 cases, but I think the results of Professor Choi is very interesting regarding the robotic in the more advanced cases. But I agree that robotic maybe not add to the T3, but maybe T4. But we have to see a larger series with a longer follow-up in order to confirm this. But we have to say that transanal and robotic are not competitive. Transanal can be more spread to do lower cost, but in the future, robotic, when the cost comes down, I think if it's available, we have to use it. But we are not here to discuss this issue with a small number of experts, but to also to pass the information to colorectal surgeons who don't have robots or other facilities. So we have to make things available for the community, not only to be for a special group of talented surgeons or having the facility to have robotics. So if we have the robotic, we have to work with the robot. But if not, we have the option of total transanal for the low rectal cancer for difficult cases, which we can proceed more with the laparoscopy.
Okay, Intak, Dr. Intak, you can go with the second question.
The second question is also for the transanal TME. The study result in presentation in today were from the learning curve or after passing the learning curve. This means the trans TME has been introduced is relatively shortly compared to robotic or laparoscopic TME. So some result might be from during the learning curve or after learning curve. So today presentation study result is during learning curve or after learning curve.
Actually, I don't think that any of us got a huge number of cases that we can, divide it into learning curve or above the learning curve. Probably we don't report the first 15 or 20 cases usually, and after you are comfortable with the technique, you start to register your cases or your data. So probably, and nobody can answer how much is the learning curve. We consider it 15 or 20. Maybe it's more, maybe it's less. For me, it's data after the first 15 cases. All these data after the first 15 cases. First 15 cases, we didn't report our data. After that, we are reporting our data.
If you allow me, I can add that in our series which we present, it's all our data, truth and nothing but the truth, starting from the first case to the last case. We have 2 cases of urethral injury, but we have an explanation for this, but it was in the early cases, of course. and we improved after that. But regarding circumferential margin, upper and lower margin, we have no difference between the early cases and late cases. And I think it's a difficult technique to learn, but we have to go through the single port abdominal, and then we can be confident to work with the transanal. We have to know a lot about the anatomy and going into the right plane in order to have good outcome.
Okay, thank you. So I will address a question to Professor Choi. Nice meeting you, Professor Choi. My name is Dr. Sarah Vesteki, President of the Emirates Society. Thank you for an interesting, really, and I've never seen actually the Da Vinci SP before, and how does it work? So thank you for introducing that to us. I have two questions for you, actually. When you did lateral pelvic lymph node dissection, when usually do you dissect them? And is there a size that you dissect the lymph nodes out? A particular size?
Yeah, of course. So when we have patient with enlarged lymph node on the either side of pelvis, when we think it is a positive, it's a 5 millimeters or larger in the short axis of the lymph node, or even smaller than that is when you show the very ugly tumor of the primary rectal tumor with the small lymph nodes. Still, we believe that is positive. That is more important than just the size only.
Exactly.
And then we do radiation, long course radiation, and re-evaluate it with the MRI before surgery, 8 weeks after treatment. But regardless of the response, we do all lateral pelvic node dissection, because we noticed that even the patient showed very good response to the lateral pelvic node dissection, the lateral pelvic node to the radiation. After several years later, we have a considerable number of recurrences for only that region. So we changed our policy.
Okay, that's actually that was I was looking for that answer. And if you faced a bulky uterus, a large uterus during your dissection, how do you manage it with the Da Vinci SP? Just it came into my mind just now.
We always hanging the uterus first.
Okay.
For the female patient, even if it's smaller or larger, we hanging with their sutures.
Yeah.
It's very tightly up to their anterior wall of the abdomen.
Great.
And otherwise, you will be in trouble when you do the pelvic. Continuously.
And if it's a very, very large uterus that takes all the pelvis and you can't hang it up, you have to consider a hysterectomy.
No.
May I add something, if you allow me? The lateral pelvic dissection needs a PET-CT to have a decision with the MRI, not the MRI alone, but the PET-CT is essential for these lymph nodes. We shouldn't go as a routine for the lateral pelvic dissection.
It is helpful, but it's not essential.
If you have lymph node more than 5 millimeters, as you mentioned, and you have a PET-CT,
even the PET-CT is negative, but still there are some percentage of positive lymph nodes. So it doesn't correlate perfectly with the PET-CT and pelvic MRI.
I think usually there is
PET-CT positive, higher probability, but you cannot say if PET-CT is negative, it is negative.
Yeah, I think there is a big debate for the lateral lymph node dissection between the Far East Asia and the rest of the world. I think all papers coming from Japan, Korea are talking about very high beneficial value of having lateral lymph node dissection. Probably it's not the same from all over the world. So probably we are respecting their data and we are respecting what they're doing. We found it, probably overdoing from our side. However, we are still respecting what you're doing. Maybe it's hard for us to do it in that way for all cases. Probably we are doing like, we are selecting cases which want to do lateral lymph node dissection. We're going to do.
Absolutely, I agree.
I know it's.
And also something regarding the bulk uterus or uterus in general. We use the nice vaginal cannula, uterine cannula used by the gynecologist. It's wonderful. The assistant holds the uterus up, and you can do it very easily. No suspension, no problem with the bulk uterus.
You need one assistant.
And you can push it anteriorly and everything up and the anterior, and everything will be fine.
But you need one more assistant, which we don't have.
Okay, you can use the usual sound or bulky Kelly clamp, but it's better to have the cannula. It's very easy to get it from the country. It's very easy.
Yeah, gynosurgeons do.
Okay, let's move to
the next question.
The next question from audience, Dr. Roger. To Dr. Roger, conversion rate of 35% seems very high for the laparoscopic arm in your study. What is any possible reasons? Yes, to Dr. Roger.
Yeah, it's very high, but it's also very honest. If we look at the Stockholm trials and all the trials in Sweden that has been done in 2010 and so on, the conversion rate was around 30%. This has come down because we get more and more experience. It's come down to approximately 10-15%. A very skilled laparoscopic surgeon will have a few percent conversion rate. But we could see that just conversion from laparoscopic to robotic reduces. We still had very high conversion rate even in the robotic arm. 11% is very high, even compared to the roller trial. Mm-hmm. But this is how it is. And then you have to ask yourself, how do you define a conversion? I mean, majority of my conversions was narrow pelvis, where I couldn't use staple laparoscopic with because we had a laparoscopic stapler and we had to convert to do the stapling and so on. So yeah, in Sweden we had that high conversions. We started laparoscopic surgery very late, but has improved. But I think laparoscopically still in Sweden it's around 15%, I think.
Yeah, I think, Roger, also probably we need to look for the definition of conversion. For example, if you both a fenestil incision and about just the TA, is this conversion?
That wasn't conversion, of course.
Yeah,
that's what we calculate. Exactly, yeah, that's what I mean.
Because some people don't consider it conversion, so that they drop their convention rate to 1% or 2%. And if you're putting these cases, probably it's going to go higher. So it depends. As long as we don't have a consensus what the conversion means for all papers, so probably we're going to have this discrepancy.
Roger, may I ask you?
Yeah.
Anyways, it's very, very nice to see you, Roger.
So nice to see you too.
And when your major causes of the conversion is narrow pelvis, failure to division of the rectum or anosmosis, and then you convert. What do you do for
that? That was the pre-robotic stapler era, when we had the SI without the robotic stapler. Since I have the robotic stapler, I don't think I have converted the last 4 or 5 years. So majority was I couldn't reach with the laparoscopic stapler, and every time we converted, I regretted myself because it wasn't so much easier, but we could actually pull with our hand much better to put the stapler on. So that was the thing. The other option is to do it from below and do a coloanal anastomosis, of course. But we did convert. That was what we did.
The other option is to have to complete with transanal, I mean.
Exactly. That's what I say. But with the robotic stapler, this is not an issue anymore, even with the narrow pelvis.
Okay. So can I ask the next question? Actually, it's to Professor Madbouly and Gerry from Professor Nasr Sani. Okay. He's asking the selection criteria that will decide whether we should do a robotic resection or a TATME. In simple terms, which rectal tumor should go for robotic resection and which one should go for TATME?
It depends who was the patient went to which surgeon. So if the patient went to Roger, he's going to do a robotic. If he comes to me, up till now, I'm going to do TATME. So it depends. I mean, every surgeon got a preference.
I think he means, Prof, if there is any limitation in TATME that will require robotics.
If you cannot do it simply, you will not know before surgery that this patient cannot have TATME. Probably you'll need to try it to see if it's going to work or not. Usually we're not having if the tumor is very low down that you cannot put the gel point, probably, I don't know whether robotic can solve this problem or not. Probably Roger can answer this question. If the tumor is very low down.
If the tumor, a T4 tumor, you won't go with the TATME approach, definitely.
Mm-hmm.
Then I would probably consider doing majority of the operation robotic, and then do extra elevator dissection APR. The question is that I would say the answer is what you feel comfortable with. And this is the thing. I think again, in Scandinavia, in Norway, we have stopped doing TATME right now, waiting for the more major studies because of the recurrence rate. And I agree, you have to have some volumes. But the thing is that in Scandinavia, in Sweden particularly, we had 2 centers doing TATME. And they were trained, they went down to LaCie, they did the proper training and so on, and they introduced the TATME. And the first 20 cases, they had too much of early recurrences, and therefore they stopped it. So I don't know. What I mean here is that TATME should not be done by every colorectal surgeon. You have to have a high volume center, because the thing is that we're trained to do the holy plane. All of a sudden with the TATME, we have to rethink our way to dissect and how we see planes and so on. So you have to start all over again. And that needs proper standardized training and volumes. And you have that criteria and you feel comfortable with that procedure, by all means. But whatever we do, we should register our patients and follow our data, because we have to give back to the future what we are doing is right or wrong. I don't have the answer, but we have to do prospective collection of data.
True. So Dr. Enta, the next question, please.
Yes, the next question is very simple question. I don't understand this question well. Is conversion from robotic to laparoscopic, how much?
Have you ever done like a procedure robotically, you started it and you went into laparoscopy?
We don't convert from, we can try sometimes. That is not a true conversion to do, because when we do the robotic procedure, we end up doing the anastomosis laparoscopic. So it still will not be a conversion. Then in that case, every robotic case is conversion. So we don't calculate it like that. But if we start a procedure, and I don't think I've ever felt like I can do it easily with laparoscopic, no, that doesn't happen.
Okay. So I think this is a question to Dr. Farag. If you made when do you make a decision to do an APR? Okay, intraoperatively, even though the MRI says that you have the plane to dissect. Is there a criteria like intraoperatively you suddenly decided to do an APR?
Yes, the intersphincteric plane is the holy plane from the inner canal point of view and from the sphincter point of view. Okay. And if this plane is infiltrated, we can't keep the sphincter, the external sphincter pubertal. So if we find that we have something wrong with the X-rays, MRI, or otherwise, and we found that this spleen had been violated by the tumor, we have to proceed, but we have to tell the patient before that we may have this problem during operation. We have their consent for the operation. But it's a very rare situation, but sometimes we are in doubt if this spleen is infiltrated or not. We keep them informed that we will check this spleen. If we find this spleen infiltrated, we have to go and remove the voluntary part of the spleen. And proceed with the APE.
I have a before last question. This is to Roger regarding ERAS.
Yeah.
So before you discharge a patient, do you do a CRP check?
No, we have standardized. We do a CRP day 1.
Day 1.
And then I do it day 2 to just see how it goes, or day 3. Usually you can see actually on day 2 if it's going, if it's just jumping out too much, you have to follow it. I follow the C-reactive protein very often with the white cell blood count, of course. But the thing is that you see when you've done all traumatic surgery and you have the C-reactive protein level of 20 day 1 or 30, you know that this is going to go into the right direction. So according to the ERAS protocol, we take day 1, and then I usually actually either day 2 or day 3, I check it again.
Okay. Can I ask the last question? Oh, yeah, go ahead, Dr. Antar. Go ahead.
Yes, I have one personal question to Dr. Choi.
Yeah.
I know Dr. Choi, he doesn't like to do transanal TME. And also Dr. Lo. Just Dr. Lo is, I think he mentioned is very important issue. Transanal TME is new techniques. And also the training is, I think, need long time compared to other new techniques. So well training and then some registration is very important for patient safety. So I don't know, today's the main subject is transanal TME versus robotic TME. Of course, just 2 hours, the presentation, we cannot conclude it exactly. But I want to ask to Dr. Professor Choi about your opinion about the transanal TME, and then what is the best approach for low rectal cancer? This means from laparoscopic or robotic and transanal TME like this.
Yeah, it's really very good question and very hard to answer correctly. But in my opinion, if you have a robot, you can do robot for TME. But the transanal approach has very advantages for very low-lying intersphincteric dissection. That actually approach opens the way to appreciate intersphincteric space more clearly than ever before. Even Eric or somebody else is already mentioned about the ISR, total, or subtotal, or partial, whatever. The TATME gave us the very clear vision how we approach from the below. But I never seen the quality of a TME better than trans-abdominal robotic TME than from below, because the avascular plane we can easily develop from the below, from the above, is very good indication for avascular plane through the interfascial space until you see the levate muscle. But below the levate muscle, robot may be difficult to see, identify the space. But that area, absolutely, I agree that from the below is a better way to find intersphincteric space.
Yeah.
So we can combine these. If you have a robot, why don't you start abdominal robotic TME with good quality of TME, and then we do the perineal approach from ISR, from below.
Thank you so much. Thank you so much.
Just a quick question for all of the speakers. And each one of you have 30 seconds to answer. We'll start first with Professor Ahmed Farag. When is your criteria to do protective ileostomy?
We used to use it as a routine. Now we had minimized this routine because we found that the low anterior resection is high after a period of diversion, and we found this in the literature. And we tested the anastomosis. We tell the patient that we have a 10% chance that we may need an urgent ileostomy in the first 10 days. And now we have this incidence of ileostomy had been decreased a lot, but I have to warn that colostomy is still valid as an option in older patients, renal patients, diabetic patients, because with the ileostomy, sometimes in the early stage, they go into renal problem or readmitted for dehydration and pre-renal azotemia. So we have to reserve the diversion for this group of patients where we are in doubt about the anastomosis, or we have to tell every patient that during the first 10 days, we have a 10% chance to have an ileostomy or a colostomy.
All right. Professor Khaled?
Actually, for me, I am more conservative. You know, if I'm not going to do a turnable cote, so I divert all coloanal anastomosis, but usually I close the diversion very early. Probably 3 weeks I close it. So after 3 weeks I do distal lobogram. If it's okay, I close it. But I'm diverting all cases if not turnable cote.
Roger?
Definitely the majority of my low rectal cancers. I'm like Khaled, I'm conservative here. If you have a leak, yeah, you can go in and you can put up a loop ileostomy, but I don't take that risk. I don't take that. I divert.
Okay. And Professor Choi, the last.
Yeah, we have 3 different categories for the protective ileostomy. When we call it safe patient, female, no CCRT, and no coloanal, we never do the ileostomy.
Okay.
The male patient with a CCRT and very low lying rectal cancer, we mostly we put the rectal tube.
Oh yeah. Okay.
Yeah, and then coloanal, we 100% we divert. So for us, the majority is a male patient who needs diversion. So female patient, even radiation or chemoradiation, we don't do mostly. We don't do ileostomy unless coloanal anastomosis.
Okay. That's basically a good summary, actually. So it seems that we reached to an end. I would like to thank our speakers for their great talks. This webinar is CME accredited by DHA. A link will be sent to your email to receive your CME certificates. The webinar is recorded and you can visit the shared link for 1 week and more. Even the previous webinar, which we did about management of early rectal cancer, is already uploaded in the platform. Please scan the QR code to have the link. Hoping to see you in the upcoming weeks. Stay safe and have a great evening. Thank you, everyone.
Thank you.
Thank you so much, everyone.
수고했어.
네, 감사합니다.
Bye. Football
Bye.
time.
Bye.